Hey, good afternoon again, and thank you for joining us on our webinar titled Comprehensive Care for Individuals with Intellectual Disability from Assessment to Advocacy, which is the final and second part of a two-series lecture on intellectual disability brought to you in collaboration with EDS Learning Institute, Yetena Weg CME, and Disability Advocacy team. So before we begin, I would like to say a few introductory remarks about Yetena Weg. Yetena Weg is registered in Pennsylvania, USA as a non-profit organization, and it's run entirely by volunteer members. We currently have more than 70 active volunteers spanning across 5 different countries and counting more. You can see their picture in the right upper hand corner. So our projects and engagements can be seen in 4 aspects. The first is our health promotion project, where we discuss and write articles regarding the health of the general public, health policy, and its implementation. Our second engagement is the community engagement, where we organize blood donation drives, inclusivity trainings, equity projects, and fundraising campaigns. Our third and one of our biggest projects is our mentorship and skill sharing, where we provide direct mentorship, soft skill, career, and professional development webinars for healthcare professionals. And the last is the medical education project, which under it has the continuing medical education, the research and quality improvement projects. So this is another slide showcasing our programs, which I've just stated in the previous slide. So our health promotion team usually works on Clubhouse sessions or on Telegram live sessions, where they prepare podcasts by inviting renowned consultants, where they can share their expertise and directly engage with the general public. They also prepare articles addressing common health issues that are geared towards the general public. Our mentorship provides direct mentorship and CPD sessions geared towards healthcare providers. Our health advocacy team usually organizes inclusivity sign language trainings. They have inclusivity SRHR trainings. They organize blood donations, and they also have they used to have previously clubhouse discussions. So our other engagement is the Yetena Weg Health article writing competition, which is done in collaboration with IMSA. The first round was announced on September 2nd last year. So Roha Medical Campus will award travel grants for 2 health article writing competition winners, whereas Yetena Weg will award pulse oximeter for the top 20 winners and litmus stethoscope for the top 3 winners. The top 5 winners will also get internship opportunities at Roha Health and other partner institutions. So we're in the middle of finalizing the winners. They will be announced shortly. Our other is the Yetena Weg Roha Research Fellowship, which is done in collaboration with Roha Medical Campus, ጥቁር አንበሳ Specialized Hospital, and St. Paul Hospital Millennium Medical College, where a research fellowship and an award was prepared. So the first round has concluded, and we're currently in the second round. So when we came to our CME team, we provide freely accessible webinars by partnering with the Ethiopian Medical Association, the Ethiopian Society of Cardiac Professionals, the Ethiopian Society of Internal Medicine, to provide continued training for healthcare professionals. So we invite both renowned local and international speakers. We've had 39 CME webinars held in the previous year. Our average webinar attendees spanned from 150 to 200 healthcare professionals. And for the year 2025, we've planned more than 30 webinars focusing on various disciplines of medicine. So you can access our previous CME sessions by going to our YouTube channel, and you can also get updates about our upcoming CMEs by joining our Yetena Weg Telegram channel for healthcare professionals or any of our social media accounts, the handles of which will be shared in the chat box below. So in order to get the best experience in the webinar, we suggest you send your questions to the Q&A or to the chat box. And at the end of the webinar, the questions will be addressed by the guest speaker. And in order to get CU certificates, you must fulfill the following set of criteria. The first is attend the whole sessions virtually. The second is fill the Google form for personal detail in attendance. Make sure to provide your correct credentials in order to avoid any issues with certification. And the third and final is you must be able to score 50% or more on the post-webinar quiz. So you may be able to see your results right away, but the certificate issuing process will take up to 2 weeks to be delivered to your email. We ask that you wait patiently in the meantime. So before introducing our guest speaker, my co-host, Dr. Jokebed, will say a few things about our Yetena Weg disability advocacy team.
Okay, thank you. Under health advocacy, we have a disability inclusion team. So our team has been active for almost 3 years, and it was able to engage in a wide range of initiatives aimed at promoting disability awareness and inclusion. Mm, So far, the team was able to increase awareness in the society about autism spectrum disorder, Down syndrome, and intellectual disability. The team was also able to collab with the Key Paperback to train deaf women on breast cancer, cervical cancer, and infertility. Our Yetena Weg disability team is committed to promote a society in the healthcare system where disabilities are fully understood, respected, and embraced. Today we have a very special guest, Dr. Jane. I'm sure you will enjoy the session.
So I'll introduce our guest speaker. Our guest speaker today is Dr. Jane Weru Paul. Is a pediatric neurodevelopmental practitioner and the founding trustee of the Pan-African Congress on Autism. She's the founder and executive director of EDS Learning Institute, an international organization that is committed to transforming the lives and communities through evidence-based training for caregivers and professionals supporting individuals with neurodevelopmental conditions. With an unwavering commitment to advancing inclusive care, Dr. Paul's mission is to ensure that every child diagnosed with a neurodevelopmental condition receives a timely, high quality, evidence based services delivered by a trained parent and or professional. She is deeply driven by the belief that no child should be left behind and works relentlessly toward this vision across local and global contexts. She currently serves as the clinical director of Excella Development Services LLC and EDS Therapies Africa, leading multidisciplinary teams in delivering comprehensive assessment, intervention, and consultation services. Her work bridges clinical excellence, cultural relevance, and sustainable capacity building across continents. So, with that said, I would like to leave the floor to Dr. Jane. Dr. Jane, it is an honor and a privilege to have you with us. Thank you, and please proceed.
Thank you. Thank you so much for that amazing introduction. I am so honored to be here, and I want to take this opportunity to thank you, organizers, for organizing this event and also for inviting me. I don't take that for granted. So thank you so much. I will go ahead and share my slides, and I think I'll go ahead and remove my picture there. Okay. I am so excited to be part of this panel. Last week, Dr. Hiba did such an amazing job of introducing the whole topic of intellectual disability. And she talked about the numbers and everything from diagnosis and a lot of information. So today I'm going to focus on comprehensive care for individuals with intellectual disability from assessment to advocacy. So last week, for those who are there, Dr. Hiba talked about history of intellectual disability, and she covered it very well. Definition and classification of intellectual disability, etiology, risk factors and comorbidities, diagnosis and assessments, management and the physician's role, which was very well covered. So thank you, Dr. Hiba. I'm not sure whether she's here today. So the objectives for today, we are going to outline key challenges and best practices in the assessment and diagnosis of intellectual disability, especially in our continent. We also identify effective strategies for developing and implementing person-centered care plans that address the holistic needs of individuals with intellectual disability in resource-limited settings, to explore the role of healthcare professionals in advocating for the rights, inclusion, and improved access to services for individuals who are diagnosed with intellectual disability and also their families. Also, the other objective will be to discuss interdisciplinary collaboration models and community-based approaches that enhance the quality of life and promote social participation for individuals with intellectual disability. The only way we are going to be effective in taking care of kids and individuals who are diagnosed with intellectual disabilities is through this interdisciplinary collaboration, because as physicians, you can't do it on your own. As practitioners who are ABA practitioners, speech therapists, occupational therapists, they cannot do it by themselves. It is going to take all of us together to really be impactful in this field. So today, I would like to focus on this unseen epidemic. Why does it matter now? Dr. Hiba last week mentioned that intellectual disability is a global reality. Yet in many parts of Africa, it remains largely unseen, misunderstood, and underserved. The statistics are often incomplete. The narratives are untold. But behind every number is a human being, a family, a community yearning for support, understanding, and opportunity. And as healthcare professionals, we are at the forefront. We are the first point of contact, the diagnosticians, the caregivers, and crucially, the advocates. And our understanding, our skills, and our commitment to making a difference can really change lives of individuals who are diagnosed with intellectual disability. Last week, we had that the way a child is diagnosed with intellectual disability is through IQ score. They have to be given an IQ test so that we can see whether they meet that range. But it's very important to understand that intellectual disability is more than an IQ score. The American Association on Intellectual and Developmental Disabilities defines ID as a disability characterized by significant limitations, both in intellectual functioning, reasoning, learning, problem solving, and in adaptive behaviors, which covers a range of everyday social and practical skills. And this disability originates before the age of 18. As we can tell from the definition, it's about both the intellectual, what we get from the IQ test, and adaptive functioning, which we may not be able to get from the IQ test. And therefore, we have to give this child other tests, and we call those skills assessment. So after diagnosis, we have to go through another set of tests so that we can see the areas the child is strong and where they need help. ID is not a disease, but a condition. When we look at the African landscape, we have unique challenges. First of all, the accurate preference data for ID in Africa is scarce. A lot of times, it's really not accurate. It is underestimated due to diagnostic challenges, stigma. We have so many children who are hidden. When a family has a child with special needs, most of the time they're hidden. So nobody gets to know that that family has a child who is diagnosed with intellectual disability. We also lack robust health information systems. However, based on last week data and also a lot of information that is on WHO website, UNESCO, the data suggests that the numbers we have are comparable to global figures and potentially higher in some areas due to factors like malnutrition, infectious diseases, and birth complications. So the unique challenges we have in Africa include stigma and misconception. We know that many times when a child is diagnosed with a special need, that is often attributed to witchcraft, curses, divine punishment, leading to isolation and neglect even by family members. We also have limited resources, scarcity of trained professionals, diagnostic tools, specialized services, and assistive technologies. And also, we face geographical barriers. Rural populations often lack access to any form of healthcare, let alone specialized care. We find that a lot of specialists are in the city, in big cities. I was born in Nairobi, in Kenya, but I know most services, especially for autism, ID, Down syndrome, a lot of services like speech, ABA, OT, you find them in the city, centralized there. So for those children who are in the villages, they face a complex challenge, and that's a big deal for our continent. The other challenge is socioeconomic factors, poverty, limiting access to nutrition, education, and healthcare. And another barrier is cultural beliefs. While some cultural beliefs can be protective, others can truly hinder acceptance and care. So when we look at these diagnosis and assessment challenges, first, we lack standardized tools. Many tools that we use were developed in the Western nations. The IQ test, like the WISC, the WASI, all were developed in the West and also normed with that population. The adaptive behavior test, also developed in the West, and they are not culturally or linguistically appropriate or normed for the African population. So every time as practitioners, whenever we are using these tools with our African children or individuals, we have to be very smart about it, knowing that the same conclusions we are able to draw with the Western born children, we cannot draw the same conclusions with our African children because the tests were not normed with them in mind. Then we have the issue of comorbidity. ID or intellectual disability often co-occurs with other conditions, epilepsy, cerebral palsy, sensory impairment, autism, Fragile X, Down syndrome, making diagnosis complex. And one thing I would like to note at this point is that in the African continent, we are able to see diagnosis of ID. I practice in the West, and I can tell you that I have not seen any child diagnosed only with intellectual disability. It's usually either autism and secondary ID, Down syndrome, secondary diagnosis, ID, Fragile X, secondary diagnosis, ID. So you will not see a child just be diagnosed as ID. And the reason why we see that a lot first is because of the diagnostic criteria changes, especially for autism, whereby a lot of children who are diagnosed with autism, maybe they could have fit the criteria for intellectual disability, but now they are able to fit the autism criteria, and ID becomes the secondary diagnosis. And as we know, for those of you who have been able to work with children who are diagnosed with autism, we know majority of them are not able to take the IQ test. So by default, they are given that diagnosis of intellectual disability as secondary, and autism becomes primary. Then we have late presentation. And we find that a lot of families are seeking help late due to lack of awareness, stigma, or financial constraint. And that is something we even see in the West, whereby families who are from minority backgrounds are seeking help late because of stigma that surrounds the diagnosis of a neurodevelopmental condition like intellectual disability. Another challenge is language barriers. Communicating with families and assessing children in diverse local languages can be difficult. Every year I have a team of professionals that travel to Kenya with me, and we are working with families in the villages. And I know one of the challenges that we face is my team who comes from the US, we have to pair them with an interpreter because they do not speak the local language. And that can be difficult because not every person is able to translate exactly what the examiner is saying. And a lot of information can be lost in translation. So that's another challenge that we face in our continent. After facing challenges, we cannot stop there. What do we do? What are best practices that we can practice in our continent so that we can serve this population of individuals? One of the things that has been very helpful, especially through EDS Learning Institute and our partnership with some Kenyan organizations, is community-based screening, whereby we have been able to train some community health workers to identify early developmental delays using culturally sensitive checklists. And I have a couple of them that I've included here, like the caregiver reported questionnaire, whereby you can actually develop one that is culturally sensitive in that particular setting where you are trying to screen. And then the MChat. The MChat is something that can be used by physicians during well baby care. It's easy. The parent get to figure it out. I put a question mark because is it culturally sensitive? The reason why I like MChat is because it follows along with developmental milestones. And the good thing about this short screening, it is just a screener. It is not a diagnostic test, but a screener. Once the parent fills out some information, we are able to know whether the child is likely to have a developmental delay. And you are able to refer from that point on. And then we have observational assessment. We can do that, whereby this one, they rely heavily on skilled observation of adaptive behaviors in natural settings, such as home and play. One of the things we started doing as an organization is training nursery school workers, because that's where children are taken to school, the first place. They are in PP1, they are baby class, PP1, PP2, PP3, and you can observe and see children who are actually showing delays in their developmental milestones. Another one is taking developmental history. Thoroughly collecting information from parents and caregivers about developmental milestones, health, and family history. And then we have this multidisciplinary team approach, which is going to be critical if we are going to make an impact in this population. Even if informal, bringing together a nurse, a social worker, community health worker, ABA therapist, speech therapist, occupational therapist, and local educator to share observation is going to be critical and life-changing. And then really coming up with referral pathways. Establishing clear, even if limited, pathways to higher level assessment when needed. As a physician, you may ask yourself, when I see a child presenting with some language delay, what is the next step? What can I tell that parent so that they can seek early intervention? And I'm going to say it right now, early intervention works. So many children who end up being in special education, if they received early intervention, that could have been changed. Not everyone, but most of them, because early intervention does work. For the time, the more than 15 years that I have been able to work in this field, I can confidently say that I stand behind early intervention fully. And the earlier the child is referred for services, the better. And then we also need to think about cultural sensitivity. We want to engage our families with respect, understanding their beliefs, and building trust, knowing that they can come and tell you how they are feeling about their child. If they are concerned, it's very important to let them know that their feelings about their child are valid, and really just affirming them and directing them to where they should go. One of the pediatricians that I've had the pleasure of working with, she is in Kenya. And every time she does a name chart and realizes that the parent, that like the child is going to be diagnosed at some point with an intellectual disability, she refers them to our parent training program as they are making a decision whether they want to start speech, whether they want to start ABA, whether they want to start OT. Because many parents, when they hear about their child actually being diagnosed with an intellectual disability, many times, most of them, their life stop right there. They are in denial and they don't know what to do, because their child is going to be diagnosed or has been diagnosed with an intellectual disability. And it's almost like they have to start over with a different child altogether, and not the one that they went to the hospital with to receive that diagnosis. So we just need to understand that families are dealing with a lot of emotions, especially when it comes to having a child diagnosed with an intellectual disability. So we're not going to do this or to discuss this, but I want you to think about this scenario. Imagine a 4-year-old child in a rural village presenting with significant language delay, difficulty with self-care tasks, and struggles interacting with peers. The parents are hesitant to seek help, fearing judgment. As a healthcare professional, what are your immediate steps for assessment and engagement? Are you going to do any screening? I would recommend you do. Are you going to refer them maybe to a psychologist to get a diagnosis if your hospital does not have diagnostic facility? Are you going to refer them to an ABA therapist? Are you going to refer them to a speech therapist, to OT therapist? What are you going to do? Whatever you do, if the child is brought to you and they are presenting delays, please do something. Don't just send that child home with nothing. And after really mentioning that, make sure you don't send home child with nothing. I would like for you to think about the referral process. What is your referral process in your clinic? So we have diagnosis. Here in the West, diagnosis means services. In our continent, it's a different animal altogether. Diagnosis does not necessarily mean that you are going to receive services, but it gives parents an answer what their child is struggling with. Maybe it's just purely intellectual disability, maybe it's autism. They now have an answer. So the first point is diagnosis. Refer them for that diagnosis. And then once they are referred out, then whenever we get the child referred to us, we do what we call skills assessment. This is where we give them adaptive assessments. We ran the VineLab on them, the adaptive behavior skill. We ran it on them. We want to see their areas of strength and where they are struggling. So we look at all developmental domains. How are they in communication? How are they socially? How about gross motor skills, fine motor skills, vocational skills, leisure skills? How are they? Cognitive skills, where are they? We take baseline data and then we develop a plan of care or the treatment plan, and we start intervention. Every child needs to at least have some intervention going, and it's very important. So I just want to encourage you, if you are, I know most of you are physicians, make sure you have a team that you can refer these children to. And I know ABA is a developing field in Africa, but ABA is a good practitioner to refer the child. Speech therapist, the same. OT therapist, the same, especially if they're having difficulties with gross motor, fine motor, and also having sensory difficulties. Having said that, the one way we are going to be able to make a big impact in this field is by engaging in early intervention. Every time I receive a referral for a 2-year-old, I am overjoyed because I know that child's brain is just developing. It's plastic. So in early intervention, we are maximizing brain plasticity. One of the most mind-blowing concepts in neuroscience is brain plasticity or neuroplasticity. The brain is an incredibly dynamic, adaptable organ, and it's constantly reorganizing itself, forming new neural connections, and strengthening existing ones in response to experiences, learning, and even injury. That means when I receive a child who is 2, who is 3, I usually say under 5, I can almost guarantee we are going to make really good progress. And from my time of service to this population, my team and I have had referrals for kids who are not even 2 yet, 18 months, 16 months, 19 months, who were very developmentally delayed. And by maximizing on this brain plasticity idea or concept, we were able to actually teach them communication. And by the time they were turning 6, they did not even qualify for special education because we had already taken care of their delayed milestones. Early intervention works. And I know many times parents have difficulties accepting the fact that their child has intellectual disabilities. And one of the sentences that my team and I always use is that we tell the parents, you know what? It's better once you notice something is not right with your child, it's better to act early and then later realize you had nothing to worry about than to wait, do nothing, and later realize that you had something to worry about. That is not something to really be happy about. Once you realize that you could have done something and you did not do it. And really, one other thing that we really encourage the parent is we realize the fact that somebody has told you that your child could have something because they have delayed the milestone, that could have set that parent in a different mindset altogether. It is okay to grieve that diagnosis. It is okay to grieve when you hear that that the child has something that you need to worry about. But as they grieve, we want them to advocate for their child. So do something as you are healing. So when we think about brain plasticity, I like to think about it as like a bustling city with roads and highways. And in a young brain, these roads are still being built, expanded, and paved. Experiences are the construction workers. So next time you have a parent and maybe you are doing well baby care and you realize something is actually not adding up, they are supposed to be having some words, they are not saying anything. Maybe instead of focusing on people, they're just focusing on objects. Please say something so that they can start receiving early intervention. And to receive early intervention, the child does not really have to have a diagnosis, but they have that delay that is visible. And based on that, they can start receiving early intervention so that they can build the person who they are referred to. If it's ABA, if it's speech, they can bridge that gap between where they need to be and where they are right now. And when we think about brain plasticity, the use it or lose it principle and the critical period is important. This plasticity is most profound in early childhood because the brain is undergoing rapid development, forming billions of connections and at an astonishing rate. And so this period, the early childhood, and when I talk about early childhood, I'm referring to below 5. So if we are referring kids who are already 5 and above, they are already late. I like to think of this critical stage as below 5. And one example that of something that is very sensitive to this critical period is language acquisition. A child exposed to language early will develop robust language pathways. A child deprived of language input during these sensitive periods will struggle far more later. Whenever we receive in our clinic a child who is not communicating and they are less than 5, we know that we can make an impact. There is a high possibility that that child will communicate if there is nothing else happening in the brain. If there is no medical condition, we know that we are going to be able to make an impact. If we receive a child who is 13 and the family wants him to talk, to develop communication, we don't say that it's going to be impossible, but it's going to be very difficult because at that point, the brain is fully developed. Having said that, early intervention is non-negotiable for ID population. Because this understanding of brain plasticity makes early intervention not just beneficial, but absolutely critical for individuals with intellectual disabilities. So the benefits of early intervention includes maximizes developmental potential because we capitalize on brain's highest plasticity, improving cognitive, motor, social, communication skills. And that's what we focus on. And as a result, we are able to see progress. Prevents secondary disabilities. When we address issues like communication, behavioral challenges, or physical limitations before they become entrenched, we are making an impact. One of the reasons why we have a lot of aberrant behaviors is because the child is not able to communicate. when they cannot communicate, they will be frustrated. And we will see that through tantrums, through aggression. And as practitioners, whenever we receive a referral, we want to know, how does this child communicate their needs and wants? And if the answer is they had lead, our responsibility and our priority is to give that child a voice. Whether it's pictures, it's sign, whatever we do to actually start communicating with them as we help them develop that vocal language. It also reduces long-term cost. Investing early can reduce the need for more intensive, expensive interventions later in life. Early intervention. Intervene early so that you do not have to invest later, too much later. Because when parents or when kids miss on early intervention, that means they're going directly to special education, and it is not cheap. If Ethiopia is like Kenya, special education is not cheap. It is not affordable. So investing in early intervention could prevent that. And I don't want to say that every child who receives early intervention improves, like gets out of special education. No, that's not what I'm saying. But many children who receive proper early intervention are able to actually make a lot of improvements in their development. It also empowers families. Every time we are providing early intervention, family is involved because we want the family to see what we are doing. We want them to be part of the program. When we are teaching communication, we want them to see how we are using the communication strategies to teach their child communication so that after the session, they can continue that same strategy. So there is powerful family empowerment. And then it promotes inclusion. Early skills development increases the likelihood of successful integration into mainstream education and community life. We have so many kids who have gone through our program, in our early intervention program, and when they go to school, they're able to be integrated. They may be receiving some special education help, maybe extra tutoring at school, but majority of the time they are with their peers, so they get to learn with typically developing peers. They get to learn social skills with their typically developing peers. Every day counts. Every interaction is an opportunity to build those neural pathways. So I just want to encourage all of you, when you see a child who is struggling, who is developmentally delayed, please refer them for early intervention. Don't wait until they are 6 to refer them. So some practical early intervention strategies in rural resource settings include home-based programs. This is where we want to train parents and caregivers to be the primary therapists, using everyday routine for learning. For example, talking to the children during feeding, when they are giving them a bath, talking with them, counting during chores, play-based learning, simple, culturally relevant games and activities that stimulate cognitive, motor, and social development. Going back to home-based programs, one of the programs that we have introduced to help resource-scarce countries like Kenya, that's where we have done the most work, has been parent-mediated intervention, where we train parents to be their children's therapists, because we realize there are therapists, yes, limited, but there is an expense part of it. It's expensive. A lot of parents cannot afford. So if you cannot afford, can you take a class? We teach you how to teach your child. And you will be surprised how many parents are willing to take these classes so that they can do home-based programs. Autism Speaks and WHO also have a free course, caregiver training, which is parents can access at no cost. And it's being practiced in Africa and other parts of the world. And that's another resource that can be used by parents. Community health worker training, equipping community health workers with basic screening tools and intervention strategies for developmental delays. One thing that EDS Learning Institute has done is to partner with the hospital in Nairobi, and we were able to train their nurses, well baby care nurses, to do simple developmental screening so that they can refer the children that are identified as at risk for developing a developmental delay or developing an intellectual disability. They're able to refer them to the clinic for early intervention, and that is something that we can do in our continent. And then parent support groups. We have several parent support groups, creating networks where parents can share experiences, learn from each other, and access basic information. I belong to a couple of parent groups. And just last week, there was a parent who is a mother to a 24-month-old baby. And I saw her post that she just received a diagnosis that her child is autistic. She was very frustrated. She was angry. She was sad. And she said, I am in denial. And then she wrote a sentence that caught my attention. She said, I have heard there are kids who get out of this. Should I just wait and see? And there is another parent who answered that question and say, oh yeah, I waited and my son started saying one word, and a lot of parents started talking to her. And I just private messaged her. I say, please, whatever your pediatrician told you, please do it. And she responded to me and said she referred me to this program and they are charging this much and I cannot afford. Do you think my child will get out of this if I wait? And I told her, I don't want you to wait. Please look for services. And if you cannot afford at this point, here are some resources. Teach yourself how to work with your child. And I connected with a parent program that we have so that she can go ahead and learn how to work with her child until she has finances so that she can get other specialized therapists. Then utilizing local materials. One of the difficulties that we have even, in our continent is adapting toys and learning aids from readily available expensive materials. So we want to adapt these materials such as pictures, textbooks. I always tell parents, you do not have to buy a textbook, which is expensive. Take pictures of daily activities. Take a picture of a cup. Take a picture of juice. Take a picture of different family members and teach your child, this is dad, this is uncle, this is sister. Teach them. You can do that. You do not have to pay a lot of money to have the materials that you need to teach your child skills. So learning how and teaching parents how to adapt toys and learning aids that are already available will be of great benefit. Focus on functional skills. We want to prioritize skills that enhance daily living and independence. self-feeding, dressing, basic communication, so that the child can at least be independent. So what is your role as a health professional in identifying early signs and initiating action? As healthcare professionals, you are often the first people to see the child. So your keen observation and plan of action is going to be life-changing. We have some general developmental red flags that really apply to most kids. Things such as lack of eye contact by 2 to 3 months, no babbling by 9 months, no single words by 16 months, no two-word phrases by 24 months, loss of previously acquired skills at any age, significant delay in motor skills, sitting, walking, lack of social reciprocity. So they're not responding to smiles, to their names. These are some red flags that you can actually pay attention to. And once you see this, please refer. So some of the things you can do: listen actively. Pay attention to parental concerns. If they say they are concerned about their child not talking, please don't tell them boys talk later. Don't tell them to wait. Encourage them to seek help, because their thoughts, their concerns are actually valid. Observe. Watch how the child interacts, plays, and communicates during the time that they are visiting you. Screen. Use simple developmental screening tools. I mentioned the MChat. There's another one called Denver 2. It's a developmental screener. ASQ3 is also a developmental screener for early, below 5. And adapted local tools. Many times you can take that tool and adapt it. I know the MChat, the developer is very responsive to people, clinics, hospital, anybody who want to adapt that tool and make it culturally sensitive, and also to translate it. They're always looking for translators into local languages. That's Diana Robbins for the MChat. Educate. Gently inform parents about developmental milestones and the importance of early intervention. Very important. I talk a lot about early intervention because I believe in it. Refer. Establish clear, even limited referral pathways to early intervention services or support group. Make sure the child does not leave your office empty-handed. They have something. You give them a plan of action, somebody they can contact. Maybe email that person if you are able to. And then we want to focus on person-centered care planning and implementation. Comprehensive care for individuals with ID extends far beyond treating medical conditions, because as for those who were here last week, we heard that many times children diagnosed with ID, they also have a lot of other medical conditions that, like epilepsy. A lot of our kids that we work with who are diagnosed with autism and intellectual disabilities, they have a lot of constipation issues because their diet is so limited. I have a child right now, he only eats bread, and therefore he is always constipated. And that means he's constantly seeing the doctor so that they can make sure he is okay internally. So it's not only about the medical, taking care of the medical condition. It's about nurturing the whole person, empowering them to live full, meaningful life. And that's why we want to take care of the whole person. Their medical part of it, their social part of it, their educational part of it. And that's why we need a team. So the core principle of person-centered care, this simply means the individual with intellectual disability and their family is at the center of every decision that we make for them. Their strength, preference, goals, and dreams guide the care plan, not just their deficit. We look at their strength. Where are they thriving? Where are they needing a lot of help? And then we incorporate all that and we ask parents, the family, what their priorities are. What would they want to see their child be able to accomplish? So when we are looking about this holistic need and care planning, we are looking at health and medical education, social and emotional, vocational, family support, and legal and protective. We want to make sure that we are safeguarding them against abuse, advocating for legal rights, and a care plan, I should mention, it's not a static document. It's a living roadmap, adapting as the individual grows and their needs evolve. The care plan for a 2-year-old is different from a care plan for an 18-year-old, because for an 18-year-old, we are looking at how can they make an impact in the community? How can we help them apply for jobs? What kind of jobs can they actually do? And when we are crafting the person-centered plan, these are some practical steps: active listening and strength-based assessment. We want to engage the individual if possible. What are their hopes? What are their strengths, interests, and preferred activities? We want to move beyond deficit, identify what they can do. One of my client right now, he is deaf and mute. And one of the things that he likes to do is work at a grocery store. We had to train him how to be a cashier, how to stock items on the shelves, and we were able to actually advocate for him to get a job coach. And that's how we were able to add value to his life. Collaborative goal setting. We want to make sure that every individual has a team, and we have set some SMART goals that are specific, measurable, achievable, relevant, and time-bound. We want to make sure we are identifying support needs and resources. What resources do we have in the community? Do we have ABA therapy that we can refer to? Do we have physical therapy if he needs physical therapy? Do we have speech? Do we have education, special education? Are there social skills trainings that are available? What are some support and resources available in the community? And some churches, especially here and also in Nairobi, they have gone above and beyond and started Sunday school for kids with special needs. So what is that a place where you can refer them, especially for those who go to church on Sundays? Those are community resources that we need to have in our referral package. And action plan and responsibilities. Who does what and when, and how are we going to monitor progress? And then regular review and adaptation. So this is mostly for people who are working with kids who are identified as having ID, intellectual disability, because care plans must be reviewed regularly, quarterly, annually, and adjusted based on progress and changing needs. For our program, we review care plans every 6 months. Another thing we need to think about is really how we can innovate in limited resource settings so that we can make it work. The training is a big deal. Group intervention. Maybe there is a speech therapist who can do volunteer group therapy. That is important to identify. Is that resource available? Telehealth, mobile health. After COVID, we realized that we can do so much through telehealth. So is that something that we can tap into? Utilizing mobile phones for remote consultations, parent education, monitoring, even basic SMS reminders. Integration into primary healthcare is another one, whereby we embed ID care within existing primary healthcare services rather than creating separate specialized clinics. That is another thing that we can think of. That's actually what we have done in our clinic in Nairobi, whereby we have kids go to well baby check, and when they are identified, the clinic, the neurodevelopmental clinic, is still in the hospital. Caregivers, providing practical trainings and emotional support to parents and primary caregivers who are often unsung heroes. Parents are struggling out there, and empowering them. Just hearing that word of encouragement will be really helpful for them. And this is a hypothetical care plan development. I'll share these slides so maybe your team can work on it. Intellectual disability who struggles with communication and social interaction. His family wants him to be more independent and make friends. Brainstorm 2 to 3 SMART goals for his care plan and identify 2 to 3 practical resource appropriate strategies to achieve with them in an African village setting. Advocacy, inclusion, and services. The healthcare professional as an advocate, you are an advocate. Your role extends beyond clinical care. We are powerful advocates for human rights and social justice. Individuals with intellectual disabilities have the same human rights. They have the same need. There is a document, CLPD, or the UN Convention on the Rights of Persons with Disabilities, which many African nations have actually ratified. Your advocacy role, speak up for your patients within the healthcare system, ensuring they receive appropriate care and challenging discrimination. Our practice, in my practice, we have dentists that we send our kids to because we know they care. We have primary care physicians we refer our kids to because we know they will receive care and they will be treated with dignity. We have pediatricians we refer our kids to because we know they treat them like they are typically developing because they are human first. And then family advocacy, empower families to understand their rights and navigate system. Community advocacy, challenge stigma, promote awareness. Whenever there is an awareness campaign, join them. The hospital can be one of the partners. Let them see you so that they see that you care. That's community advocacy. Systemic advocacy. We want to be able to identify gaps in services and contribute to policy discussions, advocating for resource allocation. And then we want to be able to combat stigma. Stigma is a huge barrier. And one way we can combat stigma is by education, using positive language, whereby we want to use person-first language, not mentally retarded child or intellectual. Yeah, the terms that many times are used in our continent are bad terms. So using positive language, showcasing abilities. One way you can showcase abilities is identify some talented kids, individuals with who are diagnosed with intellectual disabilities, maybe a painter. They paint and take that painting, put it in your office. Let the hospital wall be full of paintings that have been done by individuals with intellectual disabilities. Role modeling. Healthcare professionals treating individuals with ID, with dignity and respect, and really engaging in the community. Whenever there is something that is happening in the community, take part in that. And you want to make sure that you are ensuring access to general healthcare services, not just a specialized ID clinic. And yeah, we have already covered that. And that, yeah, and again, that interdisciplinary collaboration is so critical. No single professional can provide comprehensive care. So we need medical doctors, education, we need teachers, special education teachers, we need social services, social workers, community development workers, family, community leaders, NGOs, CBOs. We need ABAs, we need speech therapists, we need OT. And there is benefit to holistic care because we get to do really effective coordinated care. This is really just for illustrative purposes, parent-led initiatives. These are very effective, especially in our continent. Inclusive livelihood program. I know one in Nairobi where they are training individuals with intellectual disability in vocational skills like farming, which is so amazing. Village level rehabilitation, whereby you train community volunteers to provide basic therapy and support. And mobile clinic integration into traditional structures, whereby we work with community leaders to shift perceptions and encourage acceptance. And these are not just programs, they are movements.
Okay, thank you, Doctor.
Mhm.
Seems like we don't have any much more question from the audience so far, so we will proceed with the post-webinar quiz, and at the end, we will return to review the questions together with you.
Okay, so 10 minutes that have been allocated for attempting the quiz have elapsed. We're no longer accepting responses. We have 36 responses. To everyone that has managed to submit a response, thank you. So, Dr. Jane, if you're with us, my apologies. I got disconnected earlier. There was a blackout in the area I'm residing. So there were a few questions that were left unaddressed in the Q&A. So if you can see my screen, I can read them to you and we can go over them.
Okay.
Okay. So the first question was, can we use the assessment of functional living skills instead of Vineland? I found that Vineland is too expensive and a little bit difficult to use for measuring age-specific milestones.
Yes, so we can use assessment of functional living skills. I actually use it as well, but where I live, we have a set of assessment tools that we can use, that we must use, and one of them is Vineland because it gives age equivalent. But I do use AFLS because it's actually a good one, especially for my older clients. Yes, so that one you can use. It's actually a pretty good one.
Okay, thank you. The second question reads, what are the risks of over or under-diagnosing intellectual disabilities in low-resource settings?
What are the risks of over or under diagnosis? So the risks of over diagnosis, that will mean that we have a lot of kids that are being diagnosed with intellectual disabilities and maybe they do not have intellectual disabilities. And I think, I believe one of the challenge with that is if we are overdiagnosing intellectual disabilities and there are no services, that's a problem. So I would say that's a really big risk, especially in our continent. Other diagnoses, that would mean we are not diagnosing children who should be diagnosed. So it's a big risk to them because that means they're not going to be receiving medically necessary services. And so there is a risk for both of them, both under-diagnosing and over-diagnosing. One thing that is happening in the West is where we are finding that there is an overdiagnosis of autism, and maybe some children who should be diagnosed with just ID are being put in the category of autism, and therefore that poses a challenge, because that means there are so many children who are on the waiting list who actually have autism, but because there are others who don't have autism and they would benefit from other services, they are competing for the same services. So there is a risk to both overdiagnosing and underdiagnosing.
Third question reads, what gap exists in the transition of care from pediatric to adult services for individuals with intellectual disabilities, provided it's already not adequately addressed in pediatric age group, let alone adults?
Wow, that is a really good question. There is a huge gap. We are finding in developed nations, we are just getting to adult services. But I can say we are pretty good now, whereby we have very well established early intervention services, and we have very good adult services right now. But in our resource scarce continent, one of the issues, one of the big problems I have seen is that right now we are just coming up with services for children. Most people who are providing intervention, including early intervention, speech, ABA, most companies are doing under 3. So what is happening to over 3? What is happening to 8-year-olds, the high schoolers? They are left without services. And if I can talk just about Kenya, we do not have transition services beyond primary school, and that is becoming a problem. So there is a huge gap where we do not have services that can actually serve the population of students who are maybe teenagers, and parents are really struggling. So this is a good area to really provide services on, especially beyond 6 years old, providing services for that age group, and then teenagers and adulthood, so that they are not just left without anything. And that's why I was talking about person-centered care, because it doesn't just cater for the pediatrics, it caters for the whole child. When they become teenagers, they should have services. When they become adult, they should have services. I live in the state of California, and California is one of the states where by any child who is diagnosed with a neurodevelopmental condition, including ID, is put in a database, and therefore they are taken care of by the state. Insurance covers services until 21, and then they go back to the state. That's the organization that is going to take care of their living, making sure if they can work, they have job coach. If they need assistance, they have housing and all that stuff, and they have medical services, social services. And it's my hope that in the future we will have systems that are put in place in our continent. Maybe one of the African continent will be the model the model program developer for these services. But yes, there is a huge gap, an area where someone can really make an impact.
Okay, thank you. The fourth question is, what are examples of successful intersectoral approaches, such as health education, social welfare, that support comprehensive care for individuals with intellectual disability?
I can give an example for one example of a successful intersectional approach. In my practice, we have ABA therapists, we have speech therapists, and we have OT therapists, and the doctor who is the primary care physician or pediatrician, and then we do have, if the child has, maybe they have seizures, then we have a neurologist in our team. And that does not mean that we all work in the same building, but we have coordination of care meetings. In ABA, when we develop the treatment plan or the care plan, we share it with the teacher, we share it with the neurologist, we share it with the pediatrician, we share it with the speech therapist and OT. Every team member that is involved in the child's care, we share with them, and we have a copy for the parents so that everyone is aware of who is working on what. We want to know what OT is working on. We want to know what speech therapist is working on. So there is coordination of care. Because when there is no coordination of care, ABA can be working on the same goals at the speech, and nobody knows whether a particular goal has been mastered and someone is just wasting time with the child instead of moving on to the next goal because there is no coordination of care. So I highly encourage coordination of care between all the team members that are involved. If it is not possible to have physical meeting, especially with our pediatricians, it's not possible to have a physical meeting with them, but we send them the meeting notes and we let them know what we are working on, and we want to know whether they also have any concerns, and we keep the communication very open. So that is one model that is really working for us. In our clinic in Kenya, we have a pediatrician, we have a BA therapist, we have speech therapist that the child is working with, and we have an OT therapist. And one of the problems that I have seen is whereby people don't want to share the goals that they are working on. And if somebody doesn't want to share what goals they are working on, then they are not part of the team. But that is one of the difficulties we are encountering in Africa, where people get possessive of what they are working on. But it's always important, especially as the team leader, it's always important to remind the team members that it's not about them. It is about the child. And therefore, whatever they are working on, it should be open to every team member. And the parent should always be informed of what everybody is working on. And that's how we are going to make an impact with the ID population.
The fifth question reads, do you use diagnostic adaptive behavior scale for assessing adaptive behavioral skills and practices?
Yes, we do use adaptive behavior skills so that we can see the areas where the child is not thriving and the areas where they are thriving. We want to make sure that what our treatment plan is based on the real skills that the child is actually lacking. And the behavior skills are really good in looking at every domain. Communication domain, social domain, vocational domain, home living domain, cognitive domain. And based on that, we are able to develop goals to address so that we can help that child reach his or highest potential.
Thank you. The sixth and final question reads, can you talk on the outcome of children with intellectual disability from your experience?
From my experience, and as I mentioned, in our practice, especially in the West, you don't just hear about intellectual disability. Most of the time, it is secondary. And historically, if a parent got a diagnosis for the child, for his or her child, of intellectual disability, they were worried because just having intellectual disability, which was known as mental retardation, meant almost no services. And therefore, they would want another diagnosis, because another diagnosis like autism would mean more services. So here, diagnosis is pretty much attached to services. So talking about outcome for ID kids, early intervention is really what matters. When we receive children at an early age, before they are 5, the outcome is pretty good. We have, I have an example of one boy who came to us when he was 19 months. He was very severe, very severe. Aggression was on another level. The attachment to mom was very severe. Mom could not live even for a second. He had to be right there with mom, and he was 19 months. He would hate, he would bite, he would throw things. And we started working with him. We actually had 40 hours of ABA a week. That means we literally lived there. We went there at 8, we left at 4. And this boy could not even nap. Intensive care. We did that for about a year. And by the time we had finished, we were ending the first year, he started sitting down. The attachment issue lessened, the aggression was not there, and he started learning. He did not develop communication right away. He was already delayed. So we used picture exchange communication, and he became really good communicator using PECs. And we went from phase 1 to phase 6. Most of the time we don't even get there, but we went from phase 1 to phase 6. Cutting the story short, right now, the boy is 7. And last year, when he was going to school, he got assessed and he did not meet the criteria for autism for school services. He's in an inclusive setting and he developed communication. If you meet that boy today, you would not even think that he ever was diagnosed with anything. But that is one of the outcomes that we have been able to see. And that's just an example. We have many more who have been in inclusive setting. Early intervention does work. The outcome really depends on when the child starts intervention.
Thank you very much, Dr. Jane. So we've addressed all of the questions that were forwarded in the Q&A as well as the chat box. So we'll finally move to the quiz. We'll attempt them together. So I've shared my screen and I can read them to you. The first question was, according to the presentation, which of the following is not listed as a unique challenge to accurate assessment and diagnosis of intellectual disability in African contexts? The first choice is lack of standardized tools. B is stigma and misconceptions. C is geographic barriers to healthcare access. And D is abundance of specialized diagnostic centers.
And the answer is D.
Okay, thank you. The second question was, the concept of brain plasticity is highlighted in the presentation as a key reason for the importance of early intervention. What does brain plasticity primarily refer to? The first choice is the brain's dynamic ability to reorganize and form new neural corrections in response to experiences. B is the brain's resistance to any form of external stimulation. C is the brain's fixed structure after early childhood development. And D is the brain's ability to recover completely from any injury.
And the answer is A, and that's why we really need to focus on early intervention.
Thank you. The third question reads, which of the following is a core principle emphasized for comprehensive care? A is deficit-focused treatment. B is physician-led decision-making without family input. C is person-centered care. And D is institution-based care only.
And it's C, person-centered care. which is holistic.
Thank you. The final question reads, when discussing practical early intervention strategies in low resource settings, the presentation suggests which of the following as a key approach. The first choice is relying solely on highly specialized and expensive therapies. B is waiting until school age for any formal intervention. C is importing all learning materials from high-income countries. And D is training parents or caregivers to be primary therapists during everyday routines.
Yes, and the answer is D. We want to empower parents.
Okay, thank you very much. That was our final session for the webinar. So on behalf of Yetena Weg and everyone that has attended, I would like to extend our heartfelt gratitude to Dr. Jane for delivering such a practical and engaging lecture. Your insights were very informative and they were also highly relevant to our day-to-day practice and work. And thank you for the time and effort you've put into organizing this webinar. I would also like to thank my co-hosts, Dr. Israfil and Dr. Jokevid.
All right. Thank you. Thank you, everyone.
Okay, thank you everyone for joining us. We'll see you another time with another webinar. Thank you.
Thank you.